and thank you for coming to LUNGgevity. My name is Dr. Robert Reynolds. I'm a radiation oncologist here at Mosaic Life Care. Our goal this evening is to provide some education about lung cancer, screening programs, and treatment options. We have physicians from Mosaic Life Care, including Dr. Schwabe from thoracic surgery, Dr. AJ from medical oncology. We have a guest speaker from Mayo Clinic, Dr. Mansfield, who specializes in targeted therapies for lung cancer. We also have Dr. Brownfield, who has kindly offered to be our moderator tonight and help direct activities. We have invited some lung cancer survivors who have graciously offered to share their stories with us, and also to be part of a Q&A session that we'll have at the end of the event. We have several booths set up in the front I hope you were able to check out. There's Live Well St. Joe, which is a group of volunteers in St. Joe interested in breathing well, eating well, and moving well in an attempt to build a healthier community. We also have a booth for nutrition, clinical trial information, and community resources. We also have a really exciting a newly developed smoking cessation program through Mosaic Life Care called New Breath, New Life. We have a devoted group that worked hard to build this program, so please check that out. And there's also some pig lungs out there that Dr. Schwabe is playing with, so we can play with that as well. We had the help of a lot of people to make today possible. I wanted to thank Marlene Sider, our nurse navigator, who put in a lot of work in today. Also Kathy Gabler, the clinic manager of medical oncology, who helped organize this and get the food together. Jennifer Archdeacon in marketing, who helped put together this flyer and helped get the word out. And everyone at the Cancer Center, including Shauna Tai, our service line director. So without further ado, I want to introduce our moderator for today, Dr. Cynthia Brownfield. She's dual certified in both internal medicine and pediatrics. She's a frequent guest on Live at 5 and the Mosaic Life Care Clinic Minute.
Thank you all for coming. I hope that you find this very educational and very informative and a very relaxed environment. So I'd like to introduce our first guest, Dr. Jane Schwabe. She's one of Mosaic Life Care's thoracic surgeons. She has an extreme passion for really educating the community, very passionate about preventing tobacco-related illnesses. And I always enjoy watching her try to explain to the children that no, she didn't make the pigs smoke cigarettes. And she also did surgery on my mother and even saved my mother's life. So I think that she is just quite a wonderful person and great physician. So, Dr. Schwabe?
Okay, we're going to talk about our lung cancer screening program. How many of you guys out there have heard of lung cancer screening or even participated in it? Perfect, okay. Lung cancer screening, you can move forward. For years and years, we really didn't have a good, effective tool for screening for lung cancer. Chest x-rays, we've done some studies, lots of studies, in fact, that showed that chest x-rays just didn't cut it in terms of trying to find lung cancers. And that's my picture from 3 years ago when I finally quit. You can move forward. And in 2010, kind of a landmark study was released. In fact, I was fortunate enough to be at the meeting when it was released, and it was one of those, somebody comes running into the room, you guys, you'll never believe this, we've stopped this trial early because they finally not just found that lung cancer screening worked, but it had a 20% reduction in the number of cancer deaths from lung cancer just by doing low-dose CAT scans. For the first time ever, we had a tool to try to find cancers early in people who were at high risk for lung cancer. Up until then and in continuing now, lung cancer tends to give symptoms when it's really late in the course. Somebody's losing a lot of weight, they start coughing up blood, they have pain in their chest, and usually when those symptoms come along, our treatment options are limited. So we've been searching for years to try to find something we could do to find things in an earlier stage, and this is not the panacea, but it's at least a starting place. So there's been a lot of hem and hawing, the kind of working out the details of who should be screened and how we should screen and who's going to pay for the screening. Because as you can imagine, this is a very expensive undertaking for not just patients, but for insurance companies and our government. And we need to be careful that we are spending scarce resources wisely. So CMS in February came out, finally said, yes, we will cover it. the Affordable Care Act, as much as we might want to bash Obamacare, this was one of the good things it did is provide coverage for screens that met a certain threshold of benefit. And so this is one of those screens that will be covered. It's taken a little while to get it worked out, but this is the who of who should be screened. So the patients that are found to be at high risk are people between the ages of, go back, you have to excuse my flying fingers, 55 to 79, that have a 30-pack year history of smoking. So if you take the numbers of packs you smoke a day and multiply it by the years that you smoke, that's your pack year. And then if you're a former smoker, you need to have quit within the last 15 years. So that if you've quit smoking for more than 15 years, your risk of lung cancer goes markedly down, not to zero, but it goes down to kind of the general population. So those are the people that are eligible for the screen. Okay. And then this is how it's done. It's a low-dose CAT scan, so there's no IV, there's no dye. So if you have problems with your kidneys and haven't been able to do scans for other reasons, the scan is fine. Until I started studying this more in-depthly 5-7 years ago, I didn't really realize that there was radiation exposure when you flew in an airplane, but it's about the same amount of radiation in an airplane that you get when you get this low-dose CAT scan. Okay. Regular chest CT has a significantly higher amount of radiation, and that's why we don't do the conventional CAT scan for this screen. Okay, we do them here in St. Joseph at ADI, which is over by Belton Frederick, that area. We also do them down in Kansas City for people that are in the Kansas City area. Our board-certified radiologists read them, and all of them are board-certified. We don't have one particular one who reads them, they all do. We give the results to your primary care doctor, as well as Marlene's been great at calling people, and we will be having additional help for Marlene soon, so there'll be other people involved with that communication piece. And then abnormal screens are all reviewed by a multidisciplinary group. You can move it. And this kind of just gives you, sorry, leave it there. But the multidisciplinary group is a group of about 6 or 7 different specialties. We meet every Thursday morning. We go over all the abnormal lung screens. We also go over cases of patients who are in the varying stages of workup and follow-up of their cancer diagnoses. The problem with screens, and they're not perfect, just as many of you have had mammograms. A lot of us have abnormal mammograms, and a lot of us don't have breast cancer. So there's a little anxiety when you get told that there's some abnormalities in your chest CT, and about 98% of the abnormalities we find are not going to be cancer. Okay, we live in an area of the country where there's histoplasmosis, which is a kind of a fungus that lives in the soil and gets in our lungs and our lymph nodes and can grow and can look like a cancer. It can look abnormal. So a lot of the times we will find those things, and so we have a well-defined strategy of how we work it up. The National Cancer Care Network, as well as LRADS, a lung radiology kind of consortium, anyway, has a lot of great protocols for us to follow, and we follow those very religiously, so that we're not just the minute you might have something abnormal on a CAT scan, you're not whisked off to surgery, you're not whisked off to get a needle stuck in your back. We thoughtfully approach these so that we really try to limit the number of interventional things that we do to people unless we really are suspicious there's something going on. So this is just kind of a sampling of the people. We usually have somebody from radiation oncology, medical oncology, the radiologists are there, the pathologists, the surgeons are there, the pulmonologists, some of the nurse practitioners, and so just a whole group of people that have a specific interest in lung cancer, so that we can you can kind of get 8 different opinions without going to 8 different doctors' offices. So we like that. Okay. And then lastly, it was not until this year that Medicare said that they would cover it. So in typical governmental fashion, they said, yes, we'll cover it. But they didn't tell us how they were going to cover it until last week. So we've had the promise that they're going to cover it without kind of all the rules and regulations around it. And so it's a little bit of a work in progress, and there's some changes that we need to make on the doctor side of things and things that we just need to let kind of get the kinks worked out of it. So it is covered. And private insurers that are non-Medicare age, this is supposed to be screened or covered just like any other screening exam, a mammogram, colonoscopy. So there shouldn't be deductibles, but you have to check your policies and see what all the hoops and things are of that. And then why not screen everybody? You know, all of us are worried about cancers and want to be screened, and the reason is because sometimes, you know, there's risks. We don't want to expose people to unnecessary radiation. We don't want to expose people up to unnecessary anxiety or whatever, and so it's really a screen for those well-defined high-risk populations. And as the studies come in and we accumulate more data about people, we may find out that there's either broadening or narrowing of those numbers need to be done. When we first started doing the screen, it was going to be for 3 years, and if you had 3 good results, you were good. And we found that that's not good enough. So now the scan goes until you turn 79, or until you've quit smoking for more than 15 years, or until you are not well enough to where if we found something that you or your doctors would recommend treating it. So the screen's really for people who, if we found something, you'd be able to tolerate treatment of some sort. And smoking cessation is the key to this whole thing, okay? Not everybody who gets lung cancer has smoked or had significant tobacco exposure, but most of it is, and this is one of those things that none of us was born with a cigarette in our mouth. We all chose some time during our life to smoke or not to smoke, and so helping people quit smoking or educating our youth, like those lungs out in the hallway, we go to the grade schools and teach the kids, so hopefully we don't have this conversation to teach them how to quit smoking down the road that they never did, and they grew up in a society where it wasn't cool anymore to smoke. So hopefully that'll be the next wave of people coming up pike. So I just want to show you one of our first screening patients. He was a patient of mine. I'd done bypass surgery on him a few years before that, 57 years old. He had smoked for 40 years, so if you do the math, he started smoking in high school, which is pretty typical. He didn't have any symptoms. We had talked about doing the screen, and he agreed to do it. And at the time, it was a $75 scan, and he thought that was worth his investment. He didn't expect us to find anything, but he was willing to do it for me because I recommended it. So this is his screen. And you don't have to be a radiologist to see it, but you can see that white dot down there in the bottom of the screen. And so that was his spot that we came up with. And so we talked about what to do. We did a PET scan, and the PET scan was low but not negative. We talked about whether we did a needle biopsy, whether we went to surgery, what his options were, and he decided to go straight to surgery. And at that time we found that he had a stage 1 lung cancer, had his surgery and has recovered and is now several years down the road doing well and cancer-free. Had we not done the scan, we might not have found this until it was too late. And so far for the last 3 years, we've screened 445 people. Some of these are repeat screens, so we've had diagnosed 17 cancers, and you can see the stages that we found them. So those of you familiar with cancer, stage 4 is our highest stage, and we've had a couple at that stage. 1, it's 3A, 1 at 2B, and 12 at stage 1, and that's what we're hoping is find more of the early stage ones. And we have one person who's still in the workup process. We've diagnosed her cancer, but she's not been officially treated, and we don't know her final stage. She's still in the workup process. Okay, and that's just kind of the types of the fancy names of the cancers. And adenocarcinoma is the most common kind of smoking-related cancer. The others are represented a little bit. And I'd like to say that everybody's gone on to do well. But we've had a couple, unfortunately, that were early stage cancers that did go on to develop spread of their cancer within a short amount of time. A couple who have died that had the more advanced stages. But the majority of them are doing well, and I'm quite thankful that we found their cancer in a way we would never have found until they got sicker and having complications from it. So We've done a few. There were 7 biopsies that turned out to not be cancer. They were other kinds of tumors, but not cancerous tumors. A couple that were infections that looked like they could have been cancers, but they weren't. So we did do some procedures and biopsies. Only 2 people that have gone to actual operations that were not cancer, though. So that's pretty good results, considering that of the 445 people that were screened, a third of them had something on their CAT scan that we needed to follow. So we're definitely not whisking people to surgery or poking needles in people until we really have a good reason to do that. Okay, and I think we'll just do questions at the end, and I'll pass it off to Dr. Brownfield again.
Thank you, Dr. Schwabe. I still do think she probably does have a lab in her basement, and she's feeding all these little piglets, making them smoke cigarettes. So here at Mosaic Life Care, we are very fortunate to have a good relationship with Mayo Clinic. Having this relationship has allowed all of our physicians, from your primary care doctor to your top oncologist, to really work with Mayo Clinic to make sure we're giving the best treatment possible without you having to even leave your area of home. You don't have to leave St. Joe. You don't have to go to Minnesota. So we are very fortunate to have one of the Mayo Clinic medical oncologists, Dr. Mansfield, to talk about the next steps in treatment of lung cancer. So, Dr. Mansfield?
Well, thank you. It's an honor to be invited here to speak to you tonight and give you some updates on what we're doing differently with lung cancer now. But it's also a pleasure to meet the team finally in person. We've been interacting almost weekly with teleconferences and sometimes more often with phone calls. So I've been asked to give an update on how we're treating lung cancer. I'm a medical oncologist, so most of the patients I see have more advanced stages of disease. These are the ones who we're not talking about screening, but ones who have disease spread throughout their body at the time they're diagnosed. So next slide, please. So chemotherapy has been the background of our treatment for decades, but things are changing, and that's what I've been asked to talk about. So next, please. So my goals tonight are to try to give you updates on both targeted therapies and immunotherapies. Each of these topics can take days and days worth of time to discuss, but I just want to give you some broad strokes to understand how this is changing what we're doing for lung cancer.
Can you speak more into the mic?
Sorry, let me raise it for you. Is that better? So I was just saying the goals of my talk are to introduce you to targeted therapies and immunotherapies so you can understand how the treatment of lung cancer is changing. Next slide. So I have a fancy video to start with, so if you could hit play. What you see here is a patient with a tumor in their lung, and we're zooming in and we're seeing the cancer cells. And within those cancer cells is DNA. And the DNA is made up of millions and millions of little pieces called bases. And those each have names, but we've simplified it with letters here, A, C, G, and T, which is just the first letter of each name of the base pair. And what we're able to do is after we either operate on a tumor or biopsy it, we can remove the DNA from the tumors. And then there are many different ways of doing this, but we can take pieces of DNA, put it into a machine, and this is called next generation sequencing, where we're able to read the sequence of those letters. So the machine does this with lasers and some other really cool optics, but then we get that code and we resequence it. We put those pieces back into order, and then we compare that to what normal should look like, and we can find a single mutation. That's important because these mutations make abnormal proteins that tell the cells to grow and divide. And the reason that's important is we can now make drugs that target those abnormal mutations. These drugs tell the cells to stop growing, and they shrink them as you're seeing here. This may sound like voodoo or science fiction, but I want to give you a real-life example. And with the next slide. Sorry. This is an actual patient of mine that I've been treating for almost 3 years now. In the 2 panels on the left, this is a PET scan the patient had. In red, you see the tumors. The patient's left lung was completely replaced by a cancer, and you also see it lower in his body. We were able to find a mutation in a gene called ALK, and we were able to obtain the most potent ALK inhibitor available. And what you see in the 2 pictures on the right are what happened after 8 weeks of therapy. The tumors almost completely disappeared. We continued the treatment for 6 months, and then that was all that was left. So our surgeons then took out the residual disease. So even though this patient had metastatic disease to begin with, we were able to shrink it to an extent where we were then able to consider other modalities as we would for an earlier stage of lung cancer. And this patient is almost 3 years out with no evidence of disease since we met him. So this is just a real life example. This is best case scenario, but this does happen. These therapies are amazing what they can do. Next slide. So you heard earlier that adenocarcinomas are the most common type of lung cancer, and this is just one of the pie charts of what types of mutations we see in adenocarcinomas. And even though these targeted therapies are very exciting, they're not for everyone. What you see is almost 40% of patients don't have any mutations that we can detect and treat. About a quarter of patients have mutations in genes called KRAS, which we do not have any targeted drugs for yet. But then you see these other patients, smaller slivers of that pie, but about 15% of patients have mutations in a gene called EGFR, and we now have 4 drugs in the market that we can use for these. We also have patients with ALK mutations, like the one I just showed you an example of, and we currently have 2 drugs in market for those. The other mutations are found less commonly, but there are drugs in development for each of those, even though they're about 1% of the patient population. When you think about how many patients have lung cancer, it's actually thousands of people we're talking about. And one of these mutations you see up there is called BRAF. Almost half of the patients with melanoma have mutations in BRAF, and we're incorporating those drugs for melanoma into lung cancer, and they're starting to work. Next slide, please. So I had to submit my slides last Thursday. They're already out of date. On Friday, a new drug was approved. So we now have 4 drugs for EGFR. I've listed 3. For ALK, we already have 2. There are just as many in development in clinical trials. We're going to see many more come to market, and we're learning how to sequence them and integrate them in other types of care, as I'll show you in a moment. Next slide. And I'm just going to introduce to you some of the trials that are going on to change how we're treating cancer, to show where this might be in the future in the next few years. This trial is near and dear to my heart because I wrote one of the protocols for it. This is called the MATCH. Our National Cancer Institute has sponsored it, and what's happened is after patients have failed standard therapy, we can then look at their DNA, look for those mutations, and if they have one of 20 mutations that we have a targeted drug for, they can then receive that drug. So the drugs we're using for ALK are in the MATCH. Same thing for EGFR, because we're finding these mutations not only in lung cancer, but other tumors too. Next slide, please. But there are also targeted therapy trials specific to lung cancer. You heard adeno was the most common type of lung cancer. Squamous cell is probably the next most common. And we don't really have any FDA-approved therapies available yet, but the 3 most common mutations have been identified in squamous cell tumors, and trials are opening where if patients have those mutations, they can now get these drugs that target them. This is called the Master Protocol. It's open at a few sites already and opening at more. Next slide. The other thing is all the therapies I've talked about have been used in the advanced setting, but we're also trying to explore, can you use it in earlier stages of disease? So now there's something called Alchemist, that's a fancy name for the trial, where patients who've had larger lung cancers resected by the surgeons, if we find these EGFR or ALK mutations, they're then randomized to receive an EGFR or ALK inhibitor to see if it prevents recurrence. Right now the data aren't certain that it does, but there are trials going on to see if we could use these therapies in earlier stages of disease. Next slide, please. There are other things happening with targeted therapies. Right now we need biopsies to find these mutations. Blood tests are being developed so we can just get these mutations with a simple poke in the arm. Newer drugs are being developed that are more potent than the current inhibitors. Some of them are in trials now. We're also trying to sequence therapies to understand what's the best sequence of therapies to give them in. So there's a lot more that could be said about targeted therapies, but I just wanted to give a brief overview of what they are, how we find a target, and how things are changing moving forward. And with the next slide, we're going to talk a little bit about immunotherapy because there are commercials about it every 5 minutes on TV now. So believe it or not, our immune system should recognize and kill tumors. So if you play the video, here you see a lymphocyte in blue coming up to tumor cells in yellow, recognizing them and giving signals for them to die. This is how it would happen if everything were perfect. So with the next slide, the problem is tumors have gotten smart. So if you hit play, so tumors have learned to express proteins that when the immune cells identify the tumor cells, these proteins tell the immune system to ignore them. So it's taken many years, but these have been discovered over the last 20 years, these proteins that tumors express, and they shut down the immune system. So essentially the tumors are silent to the immune system. And with the next slide. So what the scientists have done is they've developed antibodies, and if you hit play, what you're going to see is these green antibodies or teal antibodies are going to come in and bind to those suppressive signals, allowing the immune system again to recognize the tumor cells and eradicate them. So with the next slide, we now have 2 drugs in market. Opdivo is probably the one you hear about every 5 minutes on TV. This is a PD-1 inhibitor, and it blocks some of that immunosuppressive signaling. That one was the first to market, but recently another drug called Keytruda that acts in a very similar way was also approved. These are approved both for adenocarcinomas and squamous cells. There are 2 other drugs that are going to come to market pretty soon. They block the ligand that the proteins bind to. It's called PD-L1. One of the drugs will probably be on market right after New Year's, and the other by the end of next year. So we have 2 drugs that are immunotherapies that are out there, 2 more that will be out there soon. And believe me, every company is trying to make their own, so many more are being tested and coming to market. So with the next slide, now that we have a basis of understanding of how these work, we're trying to combine immunotherapies together. We're trying to sequence them with chemotherapy and even sequence them with radiotherapy, which I think you'll hear more about shortly. So many more drugs are coming to market, but these are just some of the initial ones that are really changing how we treat lung cancer in the advanced setting, how we're getting away from chemotherapies or sequencing newer types of drugs with them. So with that, I think we're having questions at the end, but those were the updates I had for now.
Thank you, Dr. Mansfield. So we've heard about how we can detect lung cancer, and we've heard about new innovative treatments, but sometimes it's a little difficult to really understand how this is affecting people's lives until you hear somebody's inspiring story. So next, I'd like to have Diane Deathridge come up and tell us her inspiring story.
Thank you very much. Wow, that was amazing. I'll start my story from the very beginning. A little over a year ago, I was awakened in the middle of the night, a couple of nights in a row with a pain in my chest. And I thought, I have a history of bronchitis and pneumonia, and I thought, never previously had I had pain like that. I'd had the coughing, but not the pain. So I'm a teacher. Parent-teacher conferences were coming up soon. So I thought I'd better get to the urgent care clinic and get an antibiotic on board so that I could get ready to tackle my week ahead. So I went to urgent care in October of last year on a Saturday, and I had an x-ray. And the x-ray showed a spot, what I was told was a spot on my right lung. So I didn't get my antibiotic. I got an appointment with my physician, my primary care physician, bright and early Monday morning. I was told to just be there. And as I left, they were just so kind, but I thought, this didn't seem quite right, a spot. But I went to my physician, and the CT scan was ordered for the following day. So I was given directions that if I had any problems, to go ahead and go to ER. And that night, it was October 20th, Monday night, I did. Indeed, and my son and my sister said, "You are going." So on the way to the hospital that Monday night, midnight rolled around, and it was my son's 24th birthday, and I said, "Happy birthday, Tyler." We ventured onto the hospital, and one thing led to another, and I had my scan a little bit earlier than scheduled. One thing led to another, and on Tyler's 24th birthday, I was told that I had lung cancer. I cried on his shoulder, and I said, "Okay, let's kick this. Let's do this." That wasn't the last of my tears by any means. My friends got to hear from me too, and they got to hear my story. Things moved, as I said, very quickly after that. A PET scan, a bronchoscopy, tests, multiple tests. One thing I've learned is to expect the unexpected. When you're diagnosed with cancer, lung cancer anyway, expect the unexpected, because you never know what's going to come up. I was told after my tests that my tumor was about the size of my fist, and that it was in my upper right lobe, and it was right against my heart, very near my vena cava. So chemotherapy and radiation therapy were ordered, and so I began the treatment program. I was told a variety of things that could happen, and they did. And I learned a lot of new terms, so I kind of got a kick out of being able to say the word folliculitis, and I asked my oncologist, did I say that right? So many hospital visits, many trips in and out. But one thing about Mosaic, they work very closely, as was mentioned earlier, with Mayo. And I had asked about, the possibility of visiting with them on that. And the tumor board met several times and discussed my case. I wasn't initially a surgery candidate. I was diagnosed at a stage 3B. And the cancer was in a lymph node too, in the middle part of my body, so surgery was not a possibility. However, the outstanding physicians and the many medical personnel working on my behalf, to whom I will be forever grateful, somehow, some way, my tumor shrank considerably. And by the end of December, they were saying it had shrank a lot. So the cancer board, of course, met, and they said they think that it's a possibility. Surgery may be in the future. So as things worked out, I was indeed going to be able to have surgery. So a couple of trips to Mayo Clinic, and in Minnesota, the surgery was performed on February 9th. Of this year. They removed the upper lobe of my right lung, and they were prepared to rebuild my vena cava. As it turned out, once my surgeon chiseled the tumor, he said it was like cement. Once he chiseled the tumor away from my vena cava, it all looked pretty good, and they got the cancer out of there. Wow, I feel like the luckiest girl in the whole wide world. I came home after a considerable stay at Mayo, and my follow-up care was provided here at Mosaic, and I tell you, between Mosaic and Mayo, I feel like I got the best care any girl could ever hope to have. I went through pulmonary rehab. Those ladies are amazing. Pulmonary rehab, I completed that program. I was sent home on oxygen, and I said, I don't like this deal. I didn't want to be on oxygen the remainder of my years. So I worked very, very hard at getting off of that, and so grateful that did happen in August. I was off of oxygen, And we celebrated Tyler's 25th birthday. And we were celebrating so much more than just his 25th birthday, because I feel like I'm the luckiest person in the whole wide world. And I cannot say enough good things about the many, many, many beautiful people who were there for me. And that's my story in a nutshell, but thank you so much for allowing me to share it.
Thank you, Diana. I remember a long, long time ago in residency, it was always kind of scary to hear about a patient who had chemotherapy for whatever cancer they had to have treated. But then you add on radiation, and those times radiation would not only hit the tumor, but it would take out at the side victims, the organs that were around where you were trying to hit. So I'd like to now introduce Dr. Reynolds, who is going to talk about advances in radiation therapy.
Well, again, I'm Dr. Robert Reynolds, Radiation Oncology here at Mosaic Life Care. Yes, we've come a long way from even where we were 10 years ago with radiation therapy, so I'm here to talk about that. So the first question is, what is a radiation oncologist? I think I spend a lot of my time explaining what we do, even to sometimes other physicians. We're sort of a black box. Patients come to us and they get treated and they leave having had radiation therapy. So I think I spend a lot of time educating healthcare professionals and the public as to what we do. I spend most of my time talking with patients. People think we sit around pushing buttons all day. That's not really true. We mostly talk to patients about their diagnosis, about their stage, and about treatment recommendations, including radiation therapy. We evaluate patients in consultation. We also see them weekly when they're on treatment, and then when we see them in follow-up. So we have a huge team in the radiation oncology department, if you haven't seen it. There's, of course, the physicians, me and my partner, Dr. Goins. We also have a front office staff, we have scheduling, we have nursing assistants, we have radiation therapists that actually do the day-to-day treatments of patients and help them get on the table, get lined up, and actually get treated. We have dosimetrists, which are kind of fancy. They work with computers to help us with treatment planning, to develop the best, most conformal plan for each individual patient. So we work very closely with them. We have a radiation physicist that makes sure that whatever we do is safe and that whatever we plan is actually deliverable on the treatment machine. And they make sure that everything goes as planned with the technology. We also, of course, have an office manager. We have a dietitian. We have a social worker. We have coding specialists. We have transcriptionists, cancer registrars, who actually work to report to national databases regarding cancer incidents here in the community and in the state. And of course, we have nurse navigators like Marlene that help patients navigate all this craziness. So what is radiation therapy? So radiation is just high energy x-rays, like a CT scan or a chest x-ray. It's just much higher energy and a much higher dose to penetrate tissues and actually kill tumor cells. It's a local treatment, so I always explain that radiation's like a flashlight. It only works in the areas that I aim it, and also the side effects are only where I aim it. And it's different than chemotherapy. I think about chemotherapy as like going in and turning on a room light. It works anywhere, everywhere, all over your whole body. And radiation is more of a focal treatment. We rely heavily on imaging like CT scans, PET scans, MRIs to help us localize and know where the tumors are and know where to aim our radiation. So how does radiation work? So very similar to Dr. Mansfield's conversation, radiation works based on the DNA of cells. So radiation damages DNA and keeps them from being able to divide. Normal cells have repair mechanisms to help them repair the damage from radiation therapy. Tumor cells have downregulated a lot of this repair mechanism and are much more sensitive to radiation therapy than normal cells. And that gives us an advantage over normal cells. Radiation is often given in combination with chemotherapy. They work well together. The chemotherapy makes the cells more sensitive to the radiation. It can also be used with surgery, sometimes before surgery to make the tumor more resectable, or sometimes after surgery to clean up any microscopic disease that's been left behind after the surgery is done. And that's a picture of the DNA down there. And you can see the double-stranded break that radiation causes. So how are treatments planned? We use a CT scanner. That's actually our CT scanner in our department. And we do a simulation of the patient with using setup devices to help keep the patient in the same position every day when they're on treatment. And that's really important to make sure we're aiming at the right location and hitting the tumor and avoiding all the normal tissues. Sometimes when treating lung tumors specifically, we'll do a 4-dimensional CT scan where we actually watch the tumor move in real time while the patient's breathing. And that's important because the patient's going to be breathing while we're treating them. So we want to make sure not to miss the tumor during that phase of respiration. And we work hard with our dosimetrists and our physicists to develop a plan for the patient and avoid as many normal tissues as possible. So how is it delivered? This is a radiation treatment machine, also called a linear accelerator. They're very expensive, very large machines that deliver high dose radiation therapy. We also rely on very advanced imaging, and the better our imaging has become, the more localized we're able to give our treatments. And there are a lot of different types of treatments. It's like word salad here. So we give 3D conformal radiation therapy, intensity modulated radiation therapy, image-guided radiation therapy, volumetric modulated arc therapy, stereotactic body radiotherapy, and stereotactic radiosurgery. So you don't have to know what all those are, but we definitely use all of those to help treat our patients and give them the best treatment we can. This is an example of 3D conformal radiation therapy. It's a very simple plan. A patient came in and had a tumor in the apex of the lung, up very high. And you can see maybe here that it's affecting the top part of the heart, called the superior vena cava, where the blood returns to the heart. And if you block that, you can get blood and other fluid building up above that area. You can get swelling of the face and sometimes difficulty breathing. So it can be a medical urgency. So we wanted to get her started quickly on treatment. So we had one beam coming from the front, one beam coming from the back, and a very simple treatment to get her started immediately. And so that's the coverage we got there. We're trying to avoid the other lung as much as possible, but there's only so much you can do with just 2 beams. So in the meantime, while she was getting her first treatment, we planned a more complex treatment called intensity modulated radiation therapy. This is where we have beams going all around the patient, and we use computers to help shape the distribution of radiation therapy around the patient. There's leaves that come in and help shape the dose of radiation from each portal. And we use very complicated algorithms that computers used to take days to do, and now we can do in minutes. So it's amazing how far we've come in the last even 5 or 10 years with that. And you can see there's a picture there of all the beams surrounding the patient, and we're able to get a better dose distribution, avoid more lung tissue, have better overall avoidance of the esophagus. Then there's volumetric arc therapy. So this is where the machine goes around the patient and treats the patient the entire time that the arc is around the patient. We can change how much radiation therapy comes out at any given second, how fast the arc moves, and the dose of distribution around the patient. So this is very advanced technology that we use with the TrueBeam that we have here in St. Joe. And there's a picture of the arc going around the patient. Then we have something called stereotactic body radiation therapy. So for those patients that, let's say, have a lung screening, have found to have a very early stage tumor that's small, but may not be a candidate for surgery, we can use radiation therapy to very, very high doses per fraction and get a very good chance of cure with that. And so this is a picture of this. So we have lots of beams coming in from different angles. So it limits the radiation to any one point and really maximizes the center there. So it's like a bunch of flashlights. And where they converge in the center is the brightest spot. And so this is a treatment option that we're happy to provide, and it has made a huge difference in our patients who aren't good candidates for surgery but still clearly want to be cured of their cancer. And this is just a picture of SBRT, but we can use the VMAT, which is the arc going around the patient, and so we can also deliver SBRT that way. And We also have image-guided radiation therapy, which is the TrueBeam, which is one of the machines we have here. We were one of the first in the area to have it. And basically we do daily image guidance where we get a CT scan of the patient each day when they're on treatment and line that up with their original CT scan, make sure they're exactly in place with millimeter accuracy and reduce our uncertainty. We could also line them up to the actual tumor. So rather than relying on marks on the outside of the body, we can actually line it up to the actual lung tumor, which it makes a huge difference in lining patients up. And there's also something called stereotactic radiosurgery, where you give very high doses from very many angles. And we use this especially in the brain to give very high doses of radiation therapy to very small areas. So I wanted to have a picture of VMAT because it's kind of hard to understand. This is the lung, the tumor, and you'll see are these leaves coming in and out. As the machine rotates around the patient, the leaves move, and the computer helps us to know where the leaf should be at any given point in the position. So common questions I get as a radiation oncologist. Some are funnier than others, I guess. Will I glow in the dark? So no, you will not glow in the dark. You will not grow any extra appendages. Your children will not glow in the dark, so that's important. Does the radiation stay in my body? So none of the radiation I talked about today leaves the actual treatment room, just like a CT scan or a chest x-ray. So you're safe to be around children, you're safe to be in airports, you're not radioactive. Will radiation make my cancer spread? So I get this question a lot, and at first I didn't really understand. I think it has to do with the timing of events. So radiation does not make your cancer spread. The goal of radiation therapy is to kill cancer before it has the chance to spread. I think sometimes cancer may have already spread microscopically. We don't see it on imaging, but when we go to treat a patient, we treat them with a thought that it hasn't spread. And then afterwards, maybe it shows up somewhere else. And I think people make the association that, oh, the radiation caused my cancer to spread. And that's not true at all, okay? People always worry about getting sick from their treatments. I can tell you radiation doesn't cause nausea or vomiting. It won't limit your ability to drive or do your normal activities. It won't make you lose the hair on top of your head unless I'm treating your head, because it's a local treatment. And so in those sorts of ways, it won't make you sick. It can cause some irritation to the esophagus or irritation to the lung, and so we oftentimes treat that. How many treatments will I need? So that depends on the type and location of your cancer and what type of treatment I'm giving. The stereotactic radiotherapy is only 4 or 5 treatments. Others may be as many as 30 or 40 treatments depending on the situation. And does Medicare approve this treatment? So yes, this is a Medicare approved treatment for cancer, just like surgery or chemotherapy, okay? A lot of people want guarantees from us in the cancer community, and no cancer doctor can ever give you a guarantee that what they're doing is going to work. We do the best we can, and anybody who gives you a guarantee, you should probably run the other direction. And when will we know that it's successful? So I always tell my patients we'll know it's successful 5 years from now when we're celebrating and you're free of cancer. But I never wait 5 years to celebrate. You know, we celebrate every time we see them in follow-up, and there's always reasons to celebrate. So this is the world I live in. This is a CT scan. And so I remember every day that I don't treat scans, I treat people. And so we work very hard to heal people, give them better quality and quantity of life. And a lot of what we do, as Dr. Mansfield mentioned, is help the body to help itself. And so I think it's really important that we use radiation therapy to do that. This is a picture I found on our website. She specializes in art that actually is based on medical imaging at analytic.com. So, and we're actually using radiation therapy in clinical trials to look at if we can sensitize the immune system to the type of cancer cells that you have. So I was talking to Dr. Mansfield earlier, and there's radiating tumors to help the tumors to express their antigens or the inside of the cell on the outside and allow the immune system to actually recognize them. So we're working in tandem with medical oncologists to help that happen. And that's it.
Thank you, Dr. Reynolds. I have to admit, the glow in the dark to be kind of cool. So lung cancer, when it's detected, has unfortunately been detected at very late stages because you don't typically have symptoms until it's quite advanced. And when cancer is detected late, treatment options and chances of survivalship have not been the best. But with now new advances and even the early screening that Dr. Schwabe has talked about, we're starting to see a lot more success stories. So I'd like to introduce our next story from Johnny Coyle.
I was diagnosed with stage 4 cancer almost 4 years ago. I apparently had gotten it from Vietnam from Agent Orange. It was 50 years ago, you would consider it a death sentence, but I'm one of these guys that like to fight. I've been a fighter all my life, and it was just one more battle for me. When they told me I was in the VA clinic, I just was leaving VA with a CAT scan because I thought I had walking pneumonia. And the doctor told me I was good to go because I didn't have pneumonia anymore, and I asked him why I couldn't breathe. So they sent me back to do a CAT scan. I had no sooner left Leavenworth than I got a call that I needed to go to the office immediately. I looked at my wife and I said, well, you know, this isn't good. I'm an ex-paramedic of 37 years, and when they tell you want to see a doctor after a test, you know you're not going to get real good news. So we got into the VA clinic, and I knew it was even worse than I thought because you get all those puppy dog, I call them, sad looks. So I looked at my wife and I said, it might be a little worse than I'm thinking. So I went in and they told me I had stage 4 cancer. But it was really kind of a neat thing because Dr. Greer was when I found out I had it. His son was battling cancer, brain cancer. So I kind of shifted my thoughts about what's going on, and I kind of had a battle that I really wanted to fight. And like I said, I don't give up. So it was probably about 4 months of playing with VA, telling me they were going to start my treatments, driving to Kansas City. Every time I went, they said, well, we're going to start treatments. So my wife and I got kind of a little angry about it. And she knew somebody that had some information. They said, well, call Sam Graves, which is another guy I want to meet in person and shake his hand because he's the one that got me to where I could come into Mosaic Life Care instead of going to a VA hospital. There, once it was approved, I met this guy named AJ. Nobody could pronounce his names. I didn't even want to try. I didn't want to make him mad because the guy's treating me. So they says, oh, he goes by AJ, and we pretty much hit it off really quick. He found out I got a strange sense of humor, and I liked messing with him every time he came in. But not for him and Dr. Greer and Sam Graves, my family, which really supports me. But I always feel that you need to fight. Don't ever give up on, like I said, it used to be what they gave as a death sentence in the 50 years ago when I was 16 years old. I was always, once somebody had cancer, it was the end, get ready to go to a funeral. The Mosaic people have been really good. I go in for treatments once a month, chemo. It's not a curable cancer, but it's treatable. And I like to go in. I know a lot of the nurses. Like I said, I was a retired paramedic, and I kind of live to go in and mess with them. I used to be real good at doing IVs. They used to call me from the floor a lot of times, or to help start IVs and stuff. And so I like to go in there and kind of dare them to miss. But I always give him Dr. H.A. and the nurses in there, but they're wonderful people. They never look like they feel sorry for you, which I like. My family has been fantastic, helping me out. My wife is like a nurse hen. Kind of funny, because when I was down and out, I used to make me mad that she would want to get me something, a drink of water, because I couldn't walk from my front room to the kitchen without stopping. I couldn't breathe. But she was always there like a little mother hen trying to, I'd wanted to get up, and I said, I'll do it myself. So now we have a little running joke that I now that I can do a lot of things on my own, and I like it, but I call it playing my C card. There'll be times family's there and I say, hey, watch this. I said, honey, I'm not feeling real good. Kind of short of breath. Could you go get me a bottle of water? And she'll walk to the kitchen from the front room and give me a bottle of water, and I wink at my son or some of my family. I said, it works. Still works. So she's catching on, so I'm not getting away with it as much anymore. But it's something I like to, it makes me to get over what I got. And it's kind of a running joke with the family, and you know, now they don't believe me, so I just got the hand. But I do want to thank Mosaic for everything they've done. They're an excellent group of people, from the secretaries to the doctor in our college is really tremendous. Again, thank you, Dr. A.J. Thank you.
Thank you, Johnny. So we're going to change here a little bit. We are going to bring up a panel. You've already met several people on our panel. Dr. Schwabe and I are going to be circulating the audience, but feel free to ask any questions to Dr. Schwabe or to Dr. Mansfield, Dr. Reynolds, and then Dr. AJ. And by the way, Johnny, I can't pronounce his name either. He's going to be joining us, and Dr. AJ is one of our medical oncologists who also travels quite a far distance to treat people in surrounding communities, and is just really involved with patient safety. He's a great asset to Mosaic Life Care. I can give him a call pretty much any time with a certain case. I'm not sure which direction to go, and he always answers the phone. He always gives me the right advice, and I think the patient's always better off because of it. So we're gonna get our panel ready.
The question I have, my brother is 60 years old. He has been a smoker all his life, and he has been diagnosed with lung cancer. So he's doing radiation every day, chemo every Wednesday. And I asked him last night, what type of lung cancer do you have? Because as you stated, there's so many commercials on TV. He said he was not diagnosed with a name. So, but they would take the same approach with, you know, any type of lung cancer. So I guess my question is that normal, or, and I'm just here to learn about the lung cancer myself because I have no idea what, you know, he's going through. But
So for anyone who didn't hear the question, basically the question is based off of the lung cancer, are they all somewhat treated the same, or are they tailorized to the specific lung cancer?
because my understanding is there's multiple types of lung cancer. Is that true? I don't know.
That might be Dr. AJ.
They gave me the mic, so so no, sometimes what we do, and it's on us to keep on reminding the patients about the name. Some of us do it because of ease, where you say, this is lung cancer, and we're going to treat you, because the names are, as you realize, some names are really long and difficult to remember.
Right.
I mean, this happens to us every day. Today, daughter called and said, hey, I know you told me what my mom has. What was it again? What? So we kind of sometimes generalize for the ease for the patients, but no, there are different types. We treat them sometimes differently, or most of the time differently. So they're classified, I call them, under this big umbrella called lung cancer. That's the easiest to remember when you're being bombarded by names of scans or names of chemotherapies or names of drugs and names of radiation techniques, and you sort of forget it's lung cancer, but no, there are specific names. Yeah.
One of the questions in the back was here about stereotactic radiotherapy. So, as some of them have had to travel to Kansas City, and where are we in the line of that?
For radiosurgery. Oh, okay.
Radiosurgery for the brain.
Right, because we do stereotactic radiotherapy here. That's for the lung, and that's like the 4 or 5 treatments. The stereotactic radiosurgery we're hoping to bring online in the next couple of years. Sean. It's something I've had a lot of experience with in my training, and that I hope to bring to the people of St. Joe and surrounding communities. So. And that's basically a single fraction to the brain for limited areas in the brain that may be affected by tumor cells. So.
And if I'm right, that takes coordination with neurosurgery, and
Yes.
it's done in the operating room.
Well,
Or
it's
you
done
have
on the linear
things put
accelerators,
on-
those big machines, but
You have
done
things
in.
put on in the operating room.
There's different ways to do it. There's different ways to do radiosurgery. Sometimes we do place, actually place it into your skull when you do gamma knife radiosurgery. But there's ways to do radiosurgery on linear accelerator, like the one that we have right here in St. Joe, where you don't have to have that sort of setup. So there's different ways to do it, and we would of course have one that was able to be used in our machines here. So.
So everyone she's there, she wants to know, once you're diagnosed, how do you determine what type of treatment is for you?
So I'll take that one. First of all, you heard about the umbrella of lung cancer. We want to know what type it is. And once we know what type it is, we need to know the stage. When it's an earlier stage or a smaller tumor that's localized to the lung, sometimes we think about cutting it out with our surgeons, but not everyone can have parts of their lung removed. And then we might call our radiation oncologist to see if they can radiate that. When it's spread to the lymph nodes and is also in the lung, at that point we're not thinking surgery so much, but we're thinking of combinations of chemotherapy and radiation. When it's more advanced and it's spread beyond the lungs to other organs like the bones or liver or brain, we're typically only using chemotherapy and selectively some radiotherapy. And then I mentioned the targeted therapies and the immunotherapies. We're now looking at tumors from biopsies to see if they have these markers to help us tailor which treatments we give. So it depends on what type of tumor it is, where it is throughout the body, and what sort of markers or mutations or immunologic markers are expressed by the tumor.
Now with the advances with immunotherapy, do you see less side effects with that type of treatment compared to chemotherapy? Can you talk about that a little bit?
Sure. So the question was about the side effects for immunotherapies, and they are different than chemotherapies. Generally speaking, immunotherapies are better tolerated than chemotherapies, but patients can still feel worn down when they get them. And then when they do have side effects, sometimes they can have a rash, sometimes they have trouble breathing. These immunotherapies, they stimulate the immune system, and sometimes when you do that, the immune system will attack your own body. And when it attacks the skin, it looks like a rash. When it attacks the gut, that can cause diarrhea. When it attacks the lung, that can make you short of breath. So those side effects are not as common as the ones you get with chemotherapy, but they can be severe.
So she's on the famous TV, Optivo, okay?
And so their question is, after how many cycles, how do you know when it's working or not working?
So the question is, how many cycles should you get before you look? Opdivo is given every 2 weeks, and typically, and there's a range of what's acceptable, but usually every 2 months after starting, give or take a few weeks, is when you might get another set of scans. Sometimes you might want to get them sooner or later just based on the situation, but somewhere around a 6 to 10 week window is typical.
I was a sailor, and I had asbestos exposure on the ships. 90 years old. But here lately, I can't get my breath at all without taking my puffer right now. Every 4 hours, and it's getting more numerous. And last night I had to wake up in the middle of the night. So I don't know if it's my age. What's going on?
First off, thank you for serving our country.
Quite well.
So his question is, he was a sailor, he was exposed to asbestos, and so asbestos is one of those things that's a risk factor for not only lung cancer, but a special kind of cancer called mesothelioma, which they treat a lot of at the Mayo Clinic.
Well,
Whether that has anything to do with your shortness of breath, maybe not. So
they call it COPD.
yeah. So I think maybe when we get done, you and I can talk, and we'll, with Dr. Brownfield, see how we can maybe help you see your doctor or something sooner to help you figure out what's going on in your particular situation.
Okay,
Okay?
thank you.
I'm going to ask myself a question. And I guess I'll answer it too. But I quite often see patients, so I'm a surgeon, and people want to immediately, they come to me, they want their tumors cut out of them and removed, and who wouldn't? So what makes somebody a surgical candidate or not a surgical candidate? How do we know whether surgery is the right thing to do or not? For lung cancer, the most important thing, and you seem like you get put through 1,000 different tests, and you do, and it's for very good reasons, because we need to know what stage that cancer is, because that's how we treat it. Surgery is really best done in a situation when it hasn't spread anywhere outside of the lung where it starts, hasn't gone to the lymph nodes, hasn't gone outside of the lung cavity. But sometimes people have that pesky habit of having been a smoker before they were diagnosed, and so their lung function might not be great. So one of the things that we do besides stage and see if there's any evidence of cancer outside of the lung itself is a set of breathing tests to see what your pulmonary functions are, and to get a guesstimate of how well you would do if we had to remove a portion of your lung. Because the last thing we want to do is have a very successful operation and somebody stuck on a ventilator or crippled because they can't breathe afterwards. So getting a pulmonary function testing and sometimes more sophisticated measurements to help let us kind of guess what your lung function would be after surgery to help decide whether surgery is possible or not. So not always, unfortunately, can surgery be done safely. We have great relationships with the Mayo Clinic for some of the more complicated surgeries where we have to reconstruct part of the heart or the big blood vessels, or cancers that are invading into the wall of the chest and would require help of neurosurgeons and whatnot to remove them. So some of the more very complex procedures that we just don't do here often enough to be the experts in it will be ones like Diana, who we sent up to Mayo and had great care up there. Okay, just back to somebody. Any other questions? Shauna?
My question is for Diana and Johnny. I wonder what single piece of advice that you two might offer for others that are
I
diagnosed.
would have to say the best thing is accept any help that's offered, and also your attitude. I mean, I decided I was, it wasn't just about me. It was about my family and my friends, and I knew that if I had a nasty attitude and moped around and complained all the time, that wouldn't do them any good. So I decided right at the get-go that I wasn't going to do that. And since that time, that's one thing that they have shared with me, that helped them in dealing with it. So I guess that would be one of the big things for me, would be attitude.
I was going to say that, but everybody says I've got an attitude anyway. I don't know, I think my faith I have a lot of faith in God. I'm not, I don't think he thinks I'm done yet. I have 14 grandchildren. I want to see the last one graduate. That gives me the drive to keep on going. Amen.
Yeah.
One, I want to know how to train my husband to go get my water. I lost an aunt to lung cancer 2 weeks ago, and you often hear from breast cancer that it, and I'm not going to be clinical in any way, but it runs in the family, you know. Is that something also with lung cancer that now myself or my children need to think about? Is there any other precautionary measures that we need to take now that it's in the family, or is that not even something to worry about?
So I was handed the microphone. So the question was, are there genetic risk factors for lung cancer? The short answer is we don't have a test the way we do for breast cancer and ovarian cancer, like you've heard about these BRCA mutations maybe. We don't have a test like that for lung cancer. Most cases of lung cancer are thought to be from environmental exposures. We've talked about tobacco exposure, we've talked about asbestos. There are others, but it's thought to be primarily environmental. There is probably a small component of a genetic risk, but we do not have a single gene test to say you're at a higher or lower risk for lung cancer.
But you do need to tell your kids they can never, ever, ever smoke because Dr. Schwabi said so.
They are very, very scared of me.
Okay,
So.
well, good. They should be scared of me.
If nobody has a question, I just want to say one thing about our affiliation. And I see a lot of people here in the room that I know, and you guys know a lot of people outside probably. One thing I want to say over the last 9 years, and particularly over the last 6 years, the most important thing is to get the right care in the right place. And with the affiliation with the Mayo guys, you can be assured that what we do here, we do all as a collaboration. What Dr. Schwabi and Dr. Reynolds was talking about, every case talking about lung cancer patients is presented, looked into thoroughly, and then we make use a lot of our affiliation with Mayo, so that case is presented and sent there for the complicated, complex thing. So you're getting the best care while you're sitting here close to family, close to your home, and when we need these guys, they're just a phone call away or a video cam away, I guess, on Monday mornings.
And I'll just add to that, the majority of the cases that we discuss can be treated here. It's the more complex situations that we end up seeing. So there's a lot of care available locally, but as you know, we're there if needed.
What might be some other signs, symptoms, like Diana had said, you know, she had a pain in her chest, and he said he couldn't breathe very well. Are there other maybe symptoms that we should be looking out for that would be, hey, you need to go see your doctor? Or?
So the question is, what other symptoms might be a manifestation of lung cancer? And another one that you, other than what you've heard with pain or a cough, would be weight loss. That's another common one. But the problem is with lung cancer, symptoms develop late. It's one where there's not early symptoms most of the time. But pain, cough, trouble breathing, and weight loss are clues. But many other things can cause that.
And spitting up blood, coughing up blood is another one we would like. You can have that for non-cancer reasons, but if you have that, you need to go see your doctor.
And it's one of the reasons why lung cancer screening is so important, because by the time symptoms present, it may already be late. So if we can screen up front and catch these earlier than symptoms present, it makes a huge difference in outcomes. So if you are a smoker and you meet those criteria, you should consider lung cancer screening.
And as a primary care doctor, I would really encourage you to see your primary care doctor. I just had 2 lung cancers, and they didn't come in with cough or spitting up blood. They came in for other reasons, and one of my gentlemen came in because he had a bladder infection. But I could quickly look back a couple months ago, he weighed 20 pounds more than what he weighed now. And every year I did offer him the lung cancer screening, but he didn't want to do it. But when I saw the 20-pound weight loss, I was like, nope, you got to get a CT. And he has lung cancer, and he's currently being treated. And then another patient of mine, just this is all within the last couple of months, came in. She didn't really have any real specific complaints. She just didn't feel good. And I looked again at her last weight, and her weight was pathetic compared to her last weight that she'd come in. And so it kicked off a CT, and it was diagnosed. So I think routine seeing your primary care doctor so we can make sure that if you're losing weight, you mean to, and that you don't have an accidental weight loss. And that's really concerning if you're over age 65. Unintentional weight loss should always be evaluated.
So she's kind of asking stage-specific survival rates. And so obviously they're dependent on each specific patient, but these guys can answer kind of generalities for you. So you guys can.
Stage 3.
So stage 3 is her concern, but we could start with stage 1 and work our way down. And let's talk about non-small cell lung cancer.
I'd like to make a disclaimer about statistics. That's what they are. It's number crunching. And it's really tough to look someone in the eyes and say this is a date or a time. So when we have numbers, they're averages. And there are people who do better, there are people who do worse. So we can talk about those numbers. I just want to have the disclaimer that when we say these, it doesn't mean that's what's going to happen per se.
Having said that.
So your interest was primarily in stage 3, it sounded like, and
it is outside of the lung. In fact, it's through the ribcage and not in the spine, pressing on the spine. So there's a large mass on the spine.
so the tumor she's concerned about has been staged as a stage 3, but it sounds like the primary tumor has also gone into the bone. It also depends what population you're looking at and how healthy they are, but some stage 3s, the survival is about 25% at 5 years for patients who can receive full treatment, and not all of them can. Stage 4 is sort of changing with the drugs we have, and we're seeing it improve with immunotherapies, but it's a tough question to answer because sometimes these drugs don't work at all, and those averages are very short. But
And as you can see, he shouldn't be here if we just went by the averages and law of averages. He should be long gone, and obviously he's not. So there are people who beat the averages. So when we speak about statistics, Dr. Mansfield's exactly right that we could just give you averages, sort of like what's the average chance I'm going to die in a plane crash, Really, on a given day, you're either going to die on that plane or you're not going to die on that plane. But if you average it out over time, and so it's really hard to give, and none of us have Ouija boards or little, we can't read the future, what's going to happen for each person. We would love to be able to do that, or maybe not. But so statistics are really just kind of help us understand large groups of people, but they don't do very good at understanding one specific person. And that's why we treat everybody as hard as we can and as hard as they can tolerate.
Well, it's important to know that one of the big things that determine outcome is performance studies. So how they come to us, are they walking around, are they feeling okay? Also how much treatment they accept from us, how much treatment they tolerate, and how they respond to the treatment that we give them. So even the immunotherapies, there are people on the end of that curve that are living for years. So an average in that situation doesn't mean much when you have people, who are living for years. So I think there's a lot of other factors that come into it. We have to treat people on an individual basis. And it's part of why we have tumor boards where we discuss patients with all the providers in a multidisciplinary setting, because each patient's cancer and each patient themselves is a unique individual. And so it's hard to extrapolate and understand these numbers as averages.
And just one more thing, just to get back to the lung cancer screening, the survival for early stage disease is excellent. And that's why the lung cancer screening is so important for those at risk.
I said, and if Johnny would still remember, I used the same sentence we use to everybody. If I knew the expiration date of a person, then I won't be sitting here. So we do it, we use the clock. It says the time keeps on ticking as long as you're doing okay. It doesn't matter what the number is. We are very fair. We are very upfront. So as to tell them what the expectations are or could be, so the patient is not blindsided. But there's no expectation. As long as the patients are doing well, time keeps on ticking.
Okay, his question was he had repeating bouts of pneumonia, and they did a CAT scan and they found something abnormal and thought it looked like it could be something that histoplasmosis that we talked about, that fungus and stuff that we breathe here in this area of the country. And so they've been doing a series of CAT scans to see if it's getting bigger, worse, whatever, and he's to a point where it's kind of been stable for a few years, and the doctor told him that after another year that probably wouldn't need to scan him. And so that's sort of what our lung cancer screening is actually about. So say you were a heavy smoker in your past, I would say, no, we don't need to quit screening, we need to keep following it. But if they document that it's stable and it's been several years and it hasn't gotten any worse, and you don't have ongoing risk factors for lung cancer, it's probably okay to cut down the frequency of those tests. And it probably is in this area of the country. Without having seen your scans and all that stuff, it sounds like you're getting good advice. And it's not an uncommon thing for cancer. One of the symptoms of cough and cold, and it might look like pneumonia. They treat you with antibiotics and you feel better, and you go back to your doctor and he says, well, I want to get another chest x-ray to show whether your pneumonia is cleared. And you say, I don't need a chest x-ray. I know I'm fine, I feel good. They want to make sure that you're not one of those ones that had pneumonia because you had something blocking a bronchus or a breathing tube inside, that the pneumonia got better, but you're left with something else. So they want to make sure they're not just trying to gouge your pocketbook or Medicare's or your insurance pocketbooks. They want to make sure that there's not something underlying that. So it's important to go for those follow-ups with your primary care doctor, and then if something's abnormal, they'll get you where you need to go.
Can you define restrictive lung disease to me?
Well, I'm not a pulmonologist, but so restrictive lung disease are lungs that are kind of scarred, and so they don't expand very well. So they're kind of scarred and stiff. So lots of different things can cause restriction. Repeated bouts of pneumonia can cause it. Certain chemical inhaled, Agent Orange can do just about anything, and flu probably does make some people glow in the dark. So there's certain disease processes that can cause restrictive lung disease, and there's certain treatments. Some of it is called idiopathic, meaning we don't know why it happens, it just happens. But people who have those should probably be evaluated under the care of the lung specialist to help figure that one out.
I had a strong problem getting up and downstairs breathing, and I did a PFD. On that PFD, they determined that I had restricted lung disease, and I went through the pulmonary program up here. And it's these two things I'll tell you. Some days I was on the treadmill for 4 hours. And no problems at all. Some days it's just hard for me to get out of bed.
So it's a perplexing problem for physicians too, because like I said, there's some people we don't know why they have it, and so we don't know exactly the best way to treat it, and those people are miracle workers. Pulmonary rehab does a great job with both our lung and our heart patients. They do a great job. Somebody else had a question in the back, and that is why I'm so just out there. You guys are probably tired of hearing me in St. Joe talking about how I don't want people to smoke, and I don't want our kids to smoke, and I want to screen and check up stuff early so that we can find things when we can do something about it. Because it is not just frustrating for you all, it's frustrating for us as doctors to find stuff at a point in time where we can't do as much as we could have if we could have found it earlier.
Thank you all for coming. I hope the Longevity Conference was beneficial and informative. And I appreciate everyone from our panel. And as a final thought, according to the CDC, the tobacco industry spends $1 million on advertising every hour. So think about that. Thank you very much.